Okay. So, hello and welcome everybody. I have the privilege of talking with Nancy Clark today, a name that I always look for on programs and not just because I know I will learn something that is applicable to my practice from her talk, but because she just exudes that cardiovascular nursing passion that is contagious and that you walk away from a session thinking like, yes, I can implement this, but also I can encourage others in my work environment, and I feel very uplifted when I listen to Nancy talk. So I'm very excited to jump in today with Nancy. And I like to
Thank you,
start, Nancy,
Laura.
by asking, what did you want to be when you grew up?
You know, um, it's really interesting. That question has not come across my path for a long time. When I was younger, I didn't have a whole lot of futuristic ideas. I kind of thought for a little while I'd be a journalist. I really liked the idea of capturing a story and sharing it, being part of something that would celebrate the written word, but also in that storytelling frame. I thought long and hard about that. And I guess when I was finishing high school and applying to university, I was accepted to the Bachelor of Arts program at St. Francis Xavier in Antigonish, Nova Scotia, and I actually did a double major in English and Psych. And with Psych being the major um, that I started with, and English being my second major, and I thought long and hard about what would these two fantastic um, areas in the arts support me with. And it was in the summer after graduation. And I remember having a long conversation with my mom, who is a registered nurse and had been working my whole childhood. I understood shift, I understood 12 hours, I understood the 2 days, 2 nights, as somebody that was coming home and having supper in the fridge and had to heat it up in the microwave, one of those types of childhoods. And she goes, why don't you think about nursing? And I'm like, nursing? Oh, geez, is that hard? Just that naivety of what does mom do all day? Like, I have no idea. So I actually enrolled into nursing at the time with a Bachelor of Science in Nursing. And at the time, there was no accelerated program. So I went back to St. FX. I didn't live in Antigonish. I actually lived 3 hours away. So off I trotted back to St. FX and did the 4 year Bachelor of Science in Nursing. But because I had all those psych and English courses and that idea of writing, I ended up having to do a minor in geology. And geology is not a simple science at all. and, and how there's a lot of lab in geology. So, anyway, so I ended up getting quite a diverse education at St. FX. But it was there that I understood um, that my desire of wanting to tell people's stories, be part of that human experience, that connection, um, that I didn't think at the time was something we were losing. Um, it was the mid 90s. And I knew that I had a lot of energy and I wanted to be able to be there for people. So I actually really worked hard to become an emergency room nurse initially, which again was its own novelty because as a new grad, that was kind of like a no area. You don't jump into critical care as a novice nurse. But I was really kind of surrounded by phenomenal RNs that were very well experienced, and they took me under their wings. And I had a lot of exposure to lots of different things in rural Nova Scotia at the time. And cardiology just kept coming up and coming up. And what was it to present with chest pain? What was it to present as a motor vehicle accident because of having had chest pain? Like for me, it was this kind of thread that was happening all along. And and so then I started thinking, well, that whole idea about journalism and writing and being the storyteller was actually what I was doing. I had the privilege of doing that as a nurse, and it really kept me grounded. And so that's kind of what I think about now. Laura, it's been a long time since I thought about what I wanted to be when I grew up. And that's the story that really resonates with me, is where I thought I would go into writing, and now, many decades later, I have been doing a lot of writing. I completed a PhD last year, and that required a lot of writing. For those that are considering that level of graduate education, it was a phenomenal experience, but it was tasking and it challenging. And but I have a lot of stories, and I know that those stories are worth sharing. And so that's actually kind of full circle for me.
That's a beautiful introduction. And I feel like we can now just spend the whole next hour just talking about the idea of how nurses are in a position and have this opportunity to facilitate people's stories
Yeah.
and to enable them to be heard and the role that they play in healthcare stories and the story of Canada and all of that. Like we could spend the whole time just talking about that. And I also think it's very a theme I notice amongst a lot of these conversations, starting right back from the first one we did as a panel conversation with Sheila McKeith McCarthy and
Hmm.
Annie and John, and the theme of people I consider excellent nurses had no interest in nursing. It was a gentle guide, a gentle push.
Yeah.
Maybe they were pursuing something entirely different, like a travel agent or something like that.
Uh-huh.
Uh,
Yeah.
they get this gentle nudge of like, well, why don't you think about this? Like, you might be good. No, it's not hard. You can do it. But
Yeah.
yeah, it is. It is interesting to me how many of us didn't plan on this. And then even in the land of
Hmm.
cardiology, didn't plan on cardiology
Hmm.
either. It's just kind of like there's this theme, there's this question. It's like this little nagging that keeps
Yeah.
tapping us on the shoulder, being like, well, have you thought about the heart recently? Have you figured that case out yet? And it's so broad, it never stops.
That's
So
right. So true.
it's
So
awesome
true.
that one. So Nancy, could you run us through kind of a high level of your career journey? You've started in Nova Scotia. You're now in PEI?
Yeah.
And you were on the
Yeah.
West Coast. So
Yeah.
tell us about that journey, how you went from coast to coast, but then also kind of the roles you dabbled in along the way.
Sure. Okay. Well, you said we have an hour, so here we go. On question number two. So yeah, so I didn't know when I finished university, and like I said, I got on casual at the emergency department at St. Martha's. And at the time, there was a lot of nurses and there were a lot of people looking for work. And this is kind of how the cycles happen too in nursing, where at that stage there was a lot of nurses and not a lot of jobs. And so I had myself casual in many different small rural hospitals and a casual list. And I would go up to Cape Breton and I would work in Cape Breton and I would come back to Antigonish and I really wanted my own car. So I was really motivated to try to get some level of an FTE so that I could get a loan from the bank so I could go and get a car. And so as the years went by, probably about maybe 3 or 4 years after being mostly an emerge, but I did a lot of float too, because I think with that crash course of understanding how critical care was, even as a novice and as I was moving into my third or fourth year. And at the time, of course, being casual still meant I was working full time. I just didn't have any benefits or any credibility with the bank. Um, I was able to get a an FTE on the South Shore of Nova Scotia, and um, I had lived down there as a younger person, maybe in grade school, didn't know anybody, and I thought, you know what, this might be an okay thing. It's an FT, it's what I'm looking for, and again brought me back to emerge. But to be fair, the emerge nurses did not only work there; they had to be responsible for the med surge floor, and they had two telemetry beds, and they would have like amiodarone infusions,
And
and
you
they would do
actually grabbed my leg and pulled me closer to try.
this type of rural um, everything counts type of thing. They had a 22 bed med surge, they had an obstetrical unit, this type of thing. And I felt like I was in the zone and I was doing really
What's
well.
the day the baby shower?
And what happened was there was a big cycle and change around where were resources going to be going in healthcare in Nova Scotia. And they had decided to be best if they took some of these smaller emergency rooms and make them more like ambulatory care clinics, offering them opportunities to have more triaging centers in the bigger centers. And because of that lack of seniority and just really kind of having an FTE for all of maybe, a minute, um, I got a hold of a girlfriend that we graduated with from St. FX, and she had been working in Calgary. And she goes, Nancy, they're just really, really hungry for nurses, and St. FX has got a great reputation out here. Like, let's make our way. So off I went to Calgary, kind of on a whim, and I had interviews in the CICU, CVICU, cardiology ward, and I got 5 different offers at the time at Foothills Hospital. And I thought, I'm really going to stick with my critical care hat and go to the CICU on the 10th floor at Foothills. And that was probably one of the bravest and hardest and best decisions I had done up to that point in my career. That leap of faith of going and leaving Nova Scotia and going all the way across the country in a U-Haul. My brother drove it and towed the car. Like this was this felt really, really young at the time, and got a little duplex to rent. And um, I again was very fortunate to get into a line where the RNs, there was a real mix of experience on that line with seasoned RNs and novice. And we worked the same rotation together all the time. So it really developed that closeness and camaraderie of what it was to be on a team, and understanding too the medical school and the relationships with residents and fellows. That was all foreign to me, having only had attending and charge nurses and nurses where I was working in rural Nova Scotia at the time. And so that experience really shaped my want to know more. I became a member of CCCN at the time. I wanted to be part of a community that had like after hours things, journal clubs. There was a real strong commitment to advancing cardiology education and nursing in Calgary. And I really wanted to be part of that community. And because we were all off at the same time, the 7 or 8 of us on the team, we all kind of went to these things together. So again, it kind of really showcased that capacity to be in a group that was highly motivated with the same goals. And about 10 months after I was there, one of the questions came forward about what was my thoughts and thinking around advanced practice nursing. And the concept of nurse practitioners had not yet happened in Alberta, nor had it happened in Nova Scotia at that time. It was something that they were looking at developing, and the cardiac sciences program, along with the neurosciences program at the Foothill site mostly, were in an agreed upon relationship with the University of Calgary about starting off a program for nurse practitioners. And so in 2001, I had applied for that program, and it was the inaugural Master's Nurse Practitioner Acute Care. And I was successful in that opportunity. And there was two people from cardiology, 3 from neurosurgery. And then there were other master's courses that we would take, but there was the integral 5, the inaugural 5 that started, I believe, and graduated in August of 2003.
Nancy, can I quickly ask, did you have support through your employer or through an organization to do that, or that was
Yeah,
fully self-funded
yeah,
and own scheduling?
at the time, because it was inaugural, as most things are, there was a heavy commitment from the government as well as the institution in order to kind of guaranteed success. So then you had like a service agreement that you would have support for your education, but then you would have a service agreement to pay back that time and commitment, and that was a 2-year commitment after the fact. So it was 2 years full-time education, then you had to pay back 2 years full-time. Um, and this too was a groundbreaking, innovative phenomenon, because there was no one I could say, oh, do you know, remember how so and so did? Like, that's who I am. That's what I've done. Being the first to do something was kind of starting to be a bit of a trend for me. I was the first person to be in the emerge department as a new grad. Now I'm the first person, to be in a class that's graduating as an acute care nurse practitioner in cardiology. So there was a lot of these kind of little firsts that started to happen. And that actually continued throughout my nurse practitioner, which I specialized in medical cardiology. Over the years, I would go back and forth between the Foothills Hospital in Calgary and the Rocky View General Hospital in Calgary. And I think it might have been around 2010, I stayed at I permanently set up my space at the Rocky View Hospital. Up to that point, my colleague and I, we would kind of flip back and forth. Not quite sure of the years anymore, but anyways, sometime around then. And then I actually was able to look at where could nurse practitioners work. Um, how does it work in an acute care setting? Because everything was new, so you're kind of building the plane and flying at the same time. Like it was an interesting time, and I was highly motivated in my career. I really wanted to be successful, and I wanted my knowledge and my real, true privilege to be working with subspecialty individuals in cardiology, cardiac surgery, um, to be gleaning and learning all the different types of relationship that the nurse practitioner can have can be a little bit different sometimes than the bedside nurse. And I really wanted to take that information and bring it back to the bedside, bring it back to my nursing colleagues, and be that go between for not just our cardiology team from the cardiologist lens, the physician teams, and the patient and their families, but the nurses and the teams that are with them through their hospital stay. And so I took an opportunity in 2010 with the support of the executive directors at the Rocky View Hospital and cardiology, um, through the Libin Cardiovascular Institute, to put together a briefing note to have nurse practitioners in the coronary care unit. And so I started working on a plan to be there as the nurse practitioner. And that was the first time that that had happened. And I had that role to myself, by myself, for 9 years, when then it expanded to a 24/7 nurse practitioner um, care providing. It was a nurse practitioner led CCU at Rocky View. And that continued until I left, um, having come to the near completion of my PhD. I decided I wanted to move into an academic role, supporting nurse practitioners and research. And I don't know what happened. Almost 25 years out west, I guess. I guess a little switch flipped, and I had a desire to come back to the Maritimes. And I said the waves pulled on my heartstrings, and I made my way to Prince Edward Island, where I'm an assistant professor now at the University of PEI, teaching about the undergraduate and graduate programs here for the nurse practitioners, and of course undergraduate 4-year stream nursing, and looking at my research program around the experience of people that have recurrent acute coronary syndrome. Um, my PhD work was on younger men under the age of 55. I interviewed 13 men were in my study. I did a qualitative interpretive description methodology, and I did this over COVID. Why not? What else was going on at the time besides everything falling apart in critical care, and and taking care of people everywhere's in the hospital. So it was a tough little spot of time, but I guess I really wanted to get back to that storytelling, and sharing what was it like to be 45 years old and have a second heart attack and survive, and wonder why your stents are still okay, but now you have a new area where it needs revascularized. What was that story like for men? And the overarching theme came out saying that I'm not the same, the call for personalized cardiac care, where as nurses, we have a real strong commitment to support discharge planning at the time of admission, and how we engage with patients who have experience already in acute coronary syndrome is different than how we engage with people that are having their de novo experience. And I think that we have to be very thoughtful about that past medical history, because there's a lot of shock and awe around how this could have happened, because the language that's been occurring over time by everyone on the there's no one team that does it differently, from the point of view of being so excited with successful revascularization and commenting, you are now fixed. We did it. We got it opened. The artery is good. We're happy. The flow is happening. People hear words that they hear. They heard the word fixed. Fixed equals cure, I thought. Thank God it's not cancer. There's no cure for cancer. But my heart disease is fixed. I came in on time. I got it done. And so then fast forward 2.5, 3 years, you're back out biking. You've done your cardiac rehab. You're taking your aspirin and your statin, but you don't need to be on your beta blocker anymore. You're not taking your ACE. Things are looking good to you. And you have chest pain when you're out biking. And you're like, wait a minute, what is this? This feels hauntingly familiar to me. You go back, and now you've been told you just had another event and you had to go back to the cath lab, and here, So those were the people I was interested in hearing their story. And that concept of invincibility became very strong again with that developmental age of men under before they retire. And so that's why I focused. Sorry, I'm getting an echo. That's where I focused my PhD, and it was a passion that was um, very meaningful for me. Yeah.
Uh, Thank you for sharing that. That is quite a journey. I like the first and again, every time I talk to you, I learn something I can take back from both bedside and feel encouraged from a nursing perspective. I also have a pet peeve with like the fixed term because patients do. They hear it, they come up, and they're like, I'm fixed, I'm good to go. And I feel like the Grim Reaper coming in and being like, well, you're not actually fixed. There's no cure for coronary artery.
Yeah.
Like, you can't do this. This is a lifelong journey. We'll help you manage. And they're like, no, no, the doctor said I'm fixed. So I'm like,
Right.
well, from his perspective, he did fix the problem.
Yeah.
But yeah, no, that
I
is
know.
a
It's
good
tough.
reminder. Um, so one of the things I picked up pretty quickly, and I think you've hinted on it on purpose, is that you were fortunate to be surrounded by encouraging people, those
Yeah.
like-minded, goal-oriented people. And I would consider myself also very fortunate. The group I started with was highly motivating. Um, they set the bar high, and you just shot to hit that high bar. Throughout your career, how have you managed the transition from being the new kid on the team and just seeing like these excellent nurses that have this high bar and thinking, I want to do that, to then being, I mean, as the first NP, you were that bar. It was you could choose how high you set the bar and then how you encouraged and mentored people into hitting that bar with you. Can you talk a little bit about that process and experience?
Yeah. Um, Thank you, Laura. You know, it does take a lot to be what you think you want to be. Like it doesn't really come by chance. You do have to work. You have to put in the time. Um, and and I used to say, and I mentored many nurses. I've mentored many nurse practitioners. You have to keep showing up. Like you have to come back ready to kind of do it again and start again and look at things again. Um, Initially, when you are starting out in any area, particularly in subspecialty with medical cardiology, pattern recognition becomes your friend, right? That's a real strong way to, even when you're looking at an ECG or a rhythm strip, you're memorizing, how am I supposed to do this? You're memorizing what are certain things, memorizing certain types of labs, memorizing kind of like, the acronyms like acid beta statopril plus or minus, the dual antiplatelet. Like you're memorizing all these different things to kind of get you through so that you can be the advocate that you need to be for the patient, or to try to be able to demonstrate the findings to the physician team so that they can make help kind of deliver the care. And I think at first it's very daunting to try to say, can I meet the bar that everyone else seems to be at? And it is about that idea of, giving ourselves some grace to know that this is something that is our career. Being part of cardiac sciences is a choice. There are many choices, and as we graduate, we are kind of, certain parts of our personalities are attracted to certain parts. And I was really attracted to critical care. I was really attracted to that kind of jump in the fire and jump out. And people that know me that are on this call today, and I'm so grateful to know that they're there, they would agree that, I wasn't always going to be that nurse or nurse practitioner that was interested in the longevity of a hospital stay, or the complexities around people's multiple comorbidities that was denying their opportunity to be discharged, but their cardiology stuff was kind of wrapped up in a way. I was more the person that needed to kind of come in and settle things down when it was hot and then jump back out again. And I think that came from my experience early on in that emergency room role. But when you're asking me, there were tears. Like, to be honest, it wasn't all rainbows and unicorns. There was hard days, and there was hard days when I felt that perhaps maybe I didn't catch on fast enough. Was I there enough? Did I hear enough? Did I know enough? Did I use my stethoscope right? Did I miss something? Um, and because there's so much the nuances and in particular in cardiology, sometimes they're very subtle until now they're in your face and you're managing a code blue and you're like, this is not what I was thinking. I thought everything was fine. And it can be scary. And as a nurse and then as a nurse practitioner and moving through those times, um, it was about kind of knowing that those hard times after a while became meaningful as much as the celebration times when, as a novice nurse practitioner, and I went to emerge to do a consult and I saw a non-STEMI and they were stable and I knew I could do X, Y, and Z and I could offer them their medical management and then offer them some sort of assessment and then find out that I knew it was going to be the right coronary artery. And it was, you know what I mean? And those highs were so high um, because you knew that you knew and you could do something and you could actively be a part of something. Um, but to know too that to not have to have those extremes in the good and the bad, that the everyday things were just as important. And I think that's where I would come back and have these impromptu education opportunities with the nurses on the wards. I'd come back up to the Rocky View ward and I'd be saying, does anybody want to talk today about what it is to have, chest pain NYD? Does anybody want to talk about this ECG? Does anybody want to do this? And I would actually feed my own knowledge and soul when I had those opportunities to have these teachable moments. And sometimes they were misplaced. They're like, Nancy, we're kind of busy here. And I'm like, okay, I'll come back. And sometimes they're like, wait a minute. And they'd get on the PA system. Everybody come to the med room. We're all, Nancy's here, and people would come. And I mean, that's a big ego stroke. And it's also something that I felt really good about being able to kind of balance it all because it's not simple work that we do. And so sometimes taking the time to kind of just sit back and do an education thing um, really made me feel grounded. Yeah.
Yeah. That reminds me of two things. One, um, early in my career, there was a very messy admission coming into our CCU. There was a lot going on, and I had a lot of questions as a new nurse, and I'm watching this,
Yeah.
and it was Holly Knight, who was my half-time partner,
Yeah.
and she looked at me and
Right.
she goes, "This is an excellent learning opportunity, but not a good teaching opportunity. We'll talk
Mm.
after." I'm like, "Okay, great, thank you." Thank you for that check-in. And it seems like you had the opposite problem where you're like, I have an excellent teaching moment. And they're like, this is not a good teaching moment. This is the in the dirt, in the trench learning opportunity.
I know. I'd be so bad sometimes, but at the same time, I wanted people to know that I was there, and because the shifts, like I mean, I was doing 12-hour shifts, right? And I was there for 15 hours a day. So those were long days as the NP. Yeah.
I know those impromptu learning opportunities are worth their weight in gold. Like for everybody involved, one, they're an excellent confident booster for you. It's a great way to be involved in the team and to know what's going on. But also those like little nuggets that you get, or like I'm a real sucker for eavesdropping. If a group of nurses are looking at a cath report and they're like, "Oh, what about
Sure.
this?" I will like buddy right up into that and be like, "Well, let's talk about it." Like, because those are magical moments. One where like they're very validating for
Yeah.
what you know, but then also it feeds that enthusiasm and that education and that knowledge base and also the camaraderie of nursing. It's very,
Yeah.
very
That's exactly what a wonderful summary. Exactly. Yeah.
and then the other thing you say, and you come up and you say, "Who wants to do this? Who wants to do that?" A couple years ago, you presented a poster presentation with a young male nurse
Yeah.
on
That's right.
nitro use.
That's right. Yeah.
And you opened that presentation by saying, "Oh, I saw that the call for abstracts came out, so I went up on the floor and I said, 'Who wants to put in an abstract with me?'" And I just love that because it embodied so many things. It embodied the extracurricular engagement, embodied the mentorship, it embodied the bedside nurse asking questions and getting involved in conferences and
Yeah.
and owning their practice. And like it just encapsulated so many things that I personally love about cardiovascular nursing and CCCN and the opportunities that come all together with that into one quick 2 second story. Um, yeah, I thought that was phenomenal. And so then when the next round of abstracts came out, or call for abstracts came out, I did that. I sent out a bunch of messages to
Yeah,
some of my girlfriends being like, who wants to do a talk? And Bria and I ended up throwing together one on Ross presentations and like,
right.
because it makes it less scary. That bar is so high and it is so daunting, but if somebody comes along and says, come with me, let's do it together, it's
Yeah.
not, it's, I mean, it's still a little scary, but it's less, it's less scary as you go through that. Could you um, shine a little love on CCCN through
Of
your
course.
journey? You said you've joined it,
Of
and I know
course.
you've held a
Yes.
variety of kind of roles with CCCN a little bit as
Yes.
you've gone along. Can you tell us kind of a bit about that, about what you've done with CCCN and the why or what the benefit of that was for you?
Yeah, sure.
Mhm.
Well, for badness, Laura, I have my little CCCN pin on here tonight with my heart shirt because it is Heart Month for February. But CCCN is it was a wonderful way, like I said at the very beginning, to kind of belong to something, and initially kind of started out with being, once a year or maybe 3 times a year, people would kind of put a call for some journal club. Um, and then we'd have the conferences and they'd have the ones for the Alberta, Nunavut, Northwest Territory Conference and this type of thing. And there were some very strong nursing leaders in Alberta that had a rich cardiovascular history, and they would take the leadership, and they would put together these events, and there was so much learning, and it was so awesome to be learning from nurses, that had such a high level of knowledge around all things cardiology at the time. So as you, as the time went by, I thought, I have an opportunity here, and so I put my name in the hat and I became the provincial director for the CCCN for Alberta, Nunavut, and Northwest Territories. And it was a great experience. I had that role for 2 years and a little bit. And being part of the meetings that were held in a pan Canadian way, getting to know provincial directors across the country was it really built that idea that even though you're maybe doing something novel here in Alberta at the time, people were doing other novel things. And maybe time had gone by and it wasn't as novel anymore. And they were letting us know that it's working really well, or what doesn't work, or interprofessional education is very challenging. And so, how do you manage as a nurse practitioner when the fellow says, we don't need to talk to you right now. This is a medical training experience. Like, how do you in cardiology manage these things? And knowing that there was somebody else that had something similar in another part of the country was just a phenomenal bridge for me. I loved it. So what I thought I would do is I would go up and down the highway. And so up and down I went. From Calgary to Edmonton, and I'd go up to as far north as Fort McMurray, and I would host events. I would have support, and we'd have supper sessions, and we would do like hypertension talks in Edmonton. I would do ACS talks up in Fort McMurray. I would do all these things. I really enjoy being on the road and volunteering my time as a leader in cardiology, as a nurse practitioner, but also as the CCCN provincial director. And I did these things because I wanted to build community, and I wanted the nursing teams to know that we may be geographically spread across the province, but we are united in how we are managing care, and how, where are the different resources, and what is it like to practice in Medicine Hat when everyone has to come to Calgary for their angiogram? What's it like in Fort McMurray when everyone has to go to Edmonton? Like those types of questions. How were nurses managing these things? What was their comfort like? What was happening when they didn't have subspecialty cardiologists and they had fantastic intensivists or internists? Like, what made that different for them and their patients when they were doing these things? So this is what I did. And then I would host provincial conferences, and they were a huge hit. I had lots of great support from the CCCN executive. They knew I was doing these things. I'd have 250, 300 people attending these provincial conferences at the time. And it was a real draw. People came to Calgary, and we had a lot of fun. We had full day conferences where we had a mix of nurses and cardiologists speaking and cardiac surgeons. Big thing was happening with TAVI at the time. So TAVI was really a hot topic, and everyone's like, oh my goodness, how can we do the valve without opening the chest? Um, there was a lot of excitement. Ticagrelor was just coming onto the stream at the time. So there's a lot of things people were really worried about change, and Plavix had worked so well, clopidogrel had worked so well. Like, why do we need a new antiplatelet? What do you mean that this doesn't always work in 15% of the population? Like, these types of things were happening. And so I was part of that, and I loved that buzz. And then I did stop because I had done my term, so that was a big part of it. I do know that there are many people across the country that extend their terms and extend their terms and extend their terms. Um, but I was having a lot of pain, and I had to go forward and have a hip replacement. And so I just couldn't take the time anymore to do all this road work that I was doing. And so I just needed to take out some me time and get my hip done and recover from that. And then, get back into the work that I was supposed to be doing. Yeah.
You know what, I think there's a lot of wisdom in balancing your plate though, because I think
Yeah.
that's something that enables us to stay impassioned with our
Yeah.
projects. Every once in a while, take a little break back, pull back a second, take a breather, and then get back into it. I
Yeah.
think that helps with the longevity of nurses who have been loving cardiovascular nursing for, I'll say 20 plus years. Right? Like it, because otherwise you burn out if you extend and extend and extend. Eventually you stop creatively thinking, or the passion kind of dwindles a little bit. And yeah,
Yeah.
you do a good service in recognizing a limit and
Yeah.
stepping back from time
And
to
it was a shock. I knew it was a shock for a lot of people, but I kept my commitment. But innovation is really what I'm about. It was my middle name for a very long time,
time.
and I knew that I could do things differently. And I think after that, it's kind of where I started doing a lot more invitations. I was invited to speak at different events, and again having that collaboration with nurses. So I've done that at least a half a dozen times where nurses I've put out that call like you talked about earlier, and we've been to provincial and national conferences, and I was able to kind of share my ways of knowing um, through that, versus being the one that's running up and down the highway all the time.
Now, you did love the buzz. It sounds like you fixed your hip. I don't know if you're aware, but New Brunswick and PEI has a joint CCCN chapter that is still, I'll call it a post-COVID struggle in case you have some enthusiasm that you'd like to start up a new roadshow. There could be some interest in that offline. Uh,
Oh no, and I honestly didn't know. So thank you.
oh, okay. Yeah. Yeah.
I'm still quite new here. Yeah.
Yeah. Well, welcome to the Maritimes. It's lovely here and covered in snow
Yeah.
right now. But yeah, we're the Atlantic coast. I like many places
Yeah.
that took a bit of an enthusiasm hit during COVID for
Exactly.
something
Yeah.
extracurricular, and then like it often happens, the Atlantic provinces sometimes take a little bit longer to catch
Yeah.
back up and get enthused about these things. I love the concept of being able to tap into a network of nurses who experience things that are similar to you but are in a different place than you are, because to your point, you were doing things for the first time in Alberta, and then once you expanded into this community where there are other nurses, that maybe it was the first time they were setting it up in their province or not, maybe it wasn't, but to have some camaraderie in something that otherwise you feel totally alone. And I know right now, like our New Brunswick Heart Center is in the process of making a lot of big changes, and they're starting to explore some nurse, not quite nurse led, but nurse partnered clinic style activities, and it's very new to us. And I keep coming to CCN conferences, and they're like, "Oh, we're running this nurse led clinic here, and oh, our TAVI program is current like kind of nurse led,
Yeah.
and we've got these pharmacy led things." And New Brunswick is just starting to dabble into these things, and I've gone and I've talked to the people who are involved in them. I'm like, I know some people who do exactly what you're trying to
Yeah.
set up, because there's why reinvent the wheel if
Yeah.
you don't have to, you could modify the wheel, but to share and go on from that. Um, I didn't mention this earlier, but if anybody would like to chime in at any point, feel free to like shoot that hand up or jump right in. This is normally a pretty collaborative or like a group chat if anybody has any questions or comments and they want to jump in.
Oh, for sure. By all means, no problem.
We usually do that. And I did see also in the chat earlier, Unit 71 says hello.
Yeah, that's nice.
Yeah. I
Yeah.
don't know, it's Unit 71 in, yeah,
At Rocky View Hospital in Calgary. Yeah.
right on. So how are you finding then settling into PEI? And you're now in a more academic role, or and you finished PhD in the cardiovascular realm. How are you keeping your foot in the cardiovascular door while managing academic? What are your plans and thoughts here?
Yeah. So right now I am trying to build my research program. That's kind of why the motivation was to take an academic position full time, is to build my research program. And so this is what I'm in the middle of. Well, maybe at the beginning of, but my thinking's definitely in the middle, of building up my funding, supporting that type of part, and having partnerships develop, and looking at, again, it's very interesting. My master's work was on, being from away. And this is where I interviewed families that had come to Calgary for their intervention, like for their initial angiography assessment and then their intervention. And these would be folks that were coming usually by fixed wing aircrafts because they're coming from Medicine Hat, let's say, or more southern Alberta. And people would be worrying more because they had been stable and doing fine in these, more, not necessarily rural, but smaller centers. And then all of a sudden they're being whisked out to the airport, put on a plane, and flown to Calgary. At the time, it was a very kind of like, what's happening to me? Um, because I didn't have the ground transport to be out of the system for 7, 9 hours a day. Like that would be horrible for the care of what's happening. And so, I did my master's, thesis on being from away, and the trauma around the experiences of not having that, expertise within your hometown. And here I am in Charlottetown, and all the angiograms happen in St. John, New Brunswick, and all the interventions are happening in St. John, New Brunswick. And some people do go to Halifax, I do recognize, but the path is truly over to New Brunswick. And I'm like, this is so funny. I did this like 25 years ago, and so I'm really interested in, again, kind of exploring that Atlantic experience of healthcare where it's kind of siloed, and it's not in your back door or back pocket that, is in other centers across the country. And so that's kind of what I'm looking at. And so I'm going to kind of use my PhD work as a bit of a jump start. I understand. I'm going to now. A lot of the literature doesn't really do, gender analysis or age analysis, when it comes to, certain experiences in younger people, and so they kind of just group them together. And so I'm going to look again now that I've had this little cohort for my PhD work, expanding it and having the Atlantic focus, and what that's going to be like. So I'd be very interested to see if this is going to be comparable to the work I did, you know, back in the early 2000s when people were coming into Calgary. So that's kind of what my focus has been. The cardiologist that's here in, Charlottetown, um, I worked with in Calgary. He actually moved here about a decade ago. And so I've been in touch to say hello. And he's like, anytime you want to connect, no. And I just want to be careful, right? I've just come off a 5.5 year PhD gig while moving and working full time, and now taking on academia full time. It is a different space as a full time educator, compared to being a full time clinician, mentor, manager, and so I just don't want my plate to get so full that I can't see the forest anymore. And so I'm being a bit selfish, perhaps, and maybe just trying to slow down a little. Um, but the excitement around the work that I want to do here is real. And I am so honored to be able to kind of do this with an academic position. Yeah.
I, again, I see huge value always in kind of protecting your yeah, full of energy and have less have yeah, when we're young and full of energy and have less, maybe less responsibilities, or naive, I guess, maybe it's so easy to just hit it hard all the time, say, yeah, I can do that, I
Yeah.
can do that. And my husband and I have a saying that, like, we're happy to fill up our plate until we realized we've overfilled it, and then we're like, okay, head down for a little while. And
Yeah.
the I think it's healthier maybe to
Yeah.
slow down how quickly we fill up our plates and to evaluate,
You
like,
know,
there's not room on
there's a
that.
moment in time for things, and sometimes you do have to run, when the bulls are running, you have to go. And then there's other times when you have the opportunity to be the one holding the red flag and just saying, you guys come to me. And so that's kind of where, and this happens, I think it just happens in maturation anyways. It's nothing, I'm not doing anything special. It's just something that's just happening to me. Yeah. But
Part of that journey, that evolution, as you
yeah,
go. I am
exactly.
excited to hear about how you do some of your study. As somebody from St. John who gets those patients, and sometimes we get those patients who come alone or who come with a loved one, but they can't get back. Or
Yeah.
I think that that's a story worth visiting and hearing and exploring a little bit. I'm good. Chris, you jump on in here.
Perfect. It's been such a great talk, Nancy. One of the things I wanted to ask you about that's always been sort of forefront for me, having been involved in a CCU here in Manitoba for many, many years, and still seeing this struggle of particularly here in Manitoba. We have NPs very much involved in our cardiac sciences in the outpatient world. But there
Mhm.
doesn't seem to be, and I don't know if there's just a lack of awareness and a lack of understanding. Is it still that medical versus, that medical, what do I want to say, protection of their territory, and how you built that NP model at the Rocky View Hospital.
Yeah.
And I imagine it was you had to have had a lot of supports, but also the tenacity to then bring that model to a hospital, which I often see because I have many of my own nurses now that I'm in management that are doing their NP, that are critical
Mhm.
care nurses, and just wish that, that there were critical care opportunities, but they're not. And I sort of wonder advice or, what types of things you kind of see. And now you've been across the country, so you probably
Mhm.
have a really good perspective of what's happening in different provinces.
Yeah. And it's different in every single province. It's see, healthcare is provincially jurisdict has a provincial jurisdiction, and because of that, it's very hard to have a national pan Canadian way of looking at things, um, where people do pick up on certain things and they let other things go. And one of the things in Alberta from the very beginning is that the nurse practitioner model, which again has now fluxed again, but at the time it was an acute care only program. And so being an acute care only program did kind of push for more buy-in early from stakeholders, particularly physician environments. And that did kind of change the dynamic. And it was a very small cohort at the very beginning. And so then people were watching us. We were under a massive magnifying glass to kind of see what we did, what was the nuances, what made a nurse practitioner special, and what was it about their abilities, diagnostic reasoning, how to coming up with differential diagnosis, um, and being able to action a plan, and what the follow through was. And so there was a lot of independence and autonomy, and at the same time, in growth, there's a lot of collaboration. And sometimes there are some models of physicians that have been working in a way in a system that they do not interpret as being broken or needing to be fixed. They see that it's working for them. They know how things operate. They understand the value of control and what that looks like. And sometimes it's very hard to share in that space because of not knowing and not having trust yet. They really develop trust with nurses, and they know for sure that they can't get through the shift if the charge nurse is junior and the team is casual, and they struggle. And they know what that feels like. But at the end of the day, they get to kind of walk away, and the nurses still kind of run the show, regardless to their capacities and experiences. But as a nurse practitioner, there is a letting go a little. And sometimes that letting go is challenging for some teams. And that's the part where, that I mentioned earlier, the showing up. having that calmness and grace for ourselves and knowing that change is not simple and that small changes are happening all the time until new normals are reached. And even with all the support that I had because of the fact that this was an institution kind of support partnership with the university at the time, um, there was still a lot of resistance. They didn't understand the role. And that's the thing, is educating about the role. So I would actually go and give a lot of lunch and learns. I would go to the morning rounds. I met with zonal medical affairs. I did all these different types of things to have people understand that a nurse practitioner is not here to threaten the practice. Um, and we're not here to take away. And I do know that there's so many people that are in need of access to care, whether it's through primary care specialty practice or it's through subspecialty practice, in which I am most familiar with, that there's so much work that, wouldn't it be nice if all of us left at 7 o'clock, versus being there, at all hours of the day and night, doing routine things that you can't finish during the day. So a lot of it was advocacy around keeping things patient centered. Um, Knowing accessibility is a huge issue, remaining in that collaborative um, way of knowing that we are working together for the patient and their family to expedite their results, to be able to support discharges, to be able to improve patient flow, knowing that we can give patient education, support nursing bedside understanding, being the kind of core that actually becomes the point that you're not replaceable anymore. Um, because it's about expanding people's knowledge around what healthcare can be. And our traditional healthcare offerings are not satisfactory anymore. The complexity of folks that are coming into hospital now is totally different than what it was 20 years ago. People are not coming to hospital with a single problem. They may come with a single life threatening risk, but the combination of their multiple comorbidities behind them is a lot. And they're not getting out in the same way that we want them to. And those milestones and benchmarks are hard to meet. And so to have people on pathways and to have things kind of set up where we have that idea by rote and moving people through, um, you want it to work for many, but there are those complex chronic people that need the support of a nurse practitioner. And I think if that's the first win we get through an acute care practice, is looking at that. In critical care environments, it tends to be in that environment that the nurse practitioner excels at because they can develop relationship with the families. The turnover of the attendings every week doesn't affect the nurse practitioner. So continuity of care happens and there's a lot of bonuses around that role. And so initially it needs to have stakeholder involvement and it can't be sprung on to people. Remembering that the system is not broken for a lot of people's mindsets that are in it and working in it. It's just hard. It's hard and it's hard work, but they don't see it as something that's broken and needs to be fixed. And so, that's kind of how I navigated a lot of my briefing notes at the beginning was doing an environmental scan, how things are happening with regards to length of stay. What are some of the measurables? It's well documented. And looking at future trends around nurse practitioners, knowing that more of us are doctorally prepared, that we are contributing to the literature, that we are part of something that's robust to the health institutions in every single province. Nurse practitioners are here and we're here to stay and we're growing. We're the fastest growing profession in healthcare. And so it's about just slowly offering moments of change, but it has to be consistent. Yeah, that's the thing.
Sorry, you're so inspiring, Nancy. And I think, you know what? We need more of you at policy levels and administrative levels as well.
Yeah,
Yeah,
for sure.
yeah,
That's where decisions are made. And I had that privilege. I had that privilege.
yeah,
Um, yeah. Yeah. So
yeah.
Nancy, I was going to ask if wrapping up you had any advice for a young nurse who's a little bit daunted by the vastness of cardiovascular nursing and kind of
yeah.
that journey, but also just the whole that spiel in itself that you just gave Chris to answer her question. I'm like, oh, you could take out NP in CCU and literally insert anything and that showing up and showing your value and being irreplaceable and but accepting that it's a slow process and that it's an education process and that it's patient-centered care. I'm like, oh, that kind of that's excellent advice right in and of itself in any context in the land of nursing. But I'll still give you the chance. Do you have anything you would like to say, a nurse who is in the process of uh, in the early half of growth of their career?
Um, One of the things I used to do, remember me when I would be like, hey, do you guys want to learn this? And they'd be like, can you come back in 20? Um, but the reason why I think I would do those things is because there's so much to know and everything feels important. Um, Interpreting the telemetry strip, understanding is this a good blood pressure or not? Knowing that a systolic of 85 is not a problem so long as they're mentating and producing urine. Like, how do you know those things when our education system sets us up to understand 120 over 80 is normal and that the blood pressure is a little different if they're diabetic? We get so good at those types of things. And so what I would say to nurses that are working in cardiac sciences, and whether it's medical cardiology or cardiac surgery, is to try to know that this is going to take some time and to not jump in 2 feet and try to give her for 3, 6, 9 months and then say, this is too much. I can't do it. It's too hard. I'm never going to be okay at this. Those conversations can happen at the 5-year mark. You want to give yourself time. That's the thing. There's so many different parts to this. And what you may understand as ACS and learning about CAD and atherosclerosis, that's something to sink your teeth in because you can kind of see how that can work for somebody. Or you might focus on heart failure. But what is it about advanced heart failure? Or what is it about, infections of the valve or all these different things? There's so many different parts that I really want the nurses to know that you are there, you are doing your part, you understand risk, you understand what's modifiable and not modifiable. You may not understand all the indications for the medications we use. You may not understand all the potential risks that can happen with certain procedures, but you understand how to be there to be that advocate for your patient and how to be able to translate what the patient is saying to the rest of the team so that they have their voice heard. But coming back and doing it over and over again. Let the years come by and wash over you a bit. Don't make big judgment changes where you got to jump out of the pot because it's too hard and go and try to do something else. Hard doesn't have to hurt. Hard is meaningful. And there's so much to know that I really, really want to encourage nurses to know that there's supports when it comes to professional organizations like CCCN. If you don't have that type of support in your backyard, you too can pull up a journal article. Just go on Google and say, is there a new article today on heart attacks? Like, it doesn't have to be very academic sounding. And bring it to work and say, does anybody want to talk to me about this? Wouldn't it be fun to learn about this? And people are going to be like, yeah, you have a different understanding of fun. But today, let's try to think about this today for 15 minutes. Would it be fun to learn about this? To try to kind of fill your cup up in different ways, because these shifts are not simple shifts anymore, but it does take a long time. And I don't want anyone to get discouraged if they feel that they're kind of hitting the wall and they're like, I don't know, I don't feel comfortable, I'm scared every time I'm on duty. It's okay to be a little bit scared, but don't let that fear get in the way of how you know how to assess. You have core competencies that you have been nurturing since you've been in nursing school. And you are there to understand that your voice is the voice for the patient, and helping the patient find their voice to be able to stand up for their discharge plans and all those types of things. Maybe that's where your win. And as you move through the systems of acuity, if you're going from the ward to CCU to ICU to, multi-systems ICU environments, those environments, they need those nurses that have been there and practicing with Ernst. But I would really recommend the idea of taking those little courses on ECGs, taking the little course on the heart failure thing, jumping in on a journal club talk. If you don't have a journal club talk, make your own journal club talk. And just to give yourself that balance because that's what's going to make you feel like you're going to be able to contribute in something. Because in the beginning, I mentioned it earlier, it's all about pattern recognition, and you get really good at seeing a JVP at 3 centimeters. You get really good at seeing like a or JVD, just finding out the distension. You're like, ah, it's high. Oh, okay, what am I going to do with this? Listen to their lungs. Can you lay flat? Oh my God, you can't lay flat. And your JVD's up. Okay, dokie. There's something going on here. Those are wins. And if you thought back 4 months ago, would I have known that? Probably not. I want you to have faith in yourself. You worked really, really hard to become this nurse. It was not a simple time and program. And you just need to kind of keep coming, keep coming, keep coming, keep coming, and lean on all these other different types of resources to kind of fill up your knowledge gaps. Yeah.
Nancy, that was beautiful. Thank you. I'd like
It
to.
was a ramble, buddy. It was a
No, no,
ramble. I
that
tried.
was a full pep talk. I'm going to record it. I'm going to listen to it on my way into work every day now. Like, thank you so much for sharing that with us. That was perfect and beautiful and an excellent way to wrap us off today. Thank you so much, Nancy, for joining us today. For
Oh, I appreciate your patience, Laura. My goodness, it was the worst trying to get us to nail down this date, and it wasn't Laura. It
no,
was
it
good
was the
old Nancy
most
C. I could not make a commitment. I was the worst.
It was the most useful LinkedIn activity I've ever had in my whole life. It was fantastic. It was good. It was wonderful. I do want to put a little flag on everybody's radar for the next month. There is an Abstract 101, how to write or how to go from writing to presentations webinar that CCCN is putting on March 4th. And then I also, this is hot off the press, I haven't even told the powers that be this one yet, but I have secured a date for Sue Morris for our careers with our this talk, sorry, our journey through cardiovascular nursing for March 18th. So if you want to put a little pencil that in on your schedules too, that's there as well. And of course, spring conference is coming to Saskatchewan in May, the end of May. So you have time to book and time to come in there. Thank you so much for coming.